Excuse me, everyone. We now have all our speakers in conference. Please note that participation on this call is by express written invitation from the AHA for AHA members only. Unauthorized participants and or any party that aids unauthorized participants may be subject to criminal and civil penalties under both state and federal law, including the Electronic Privacy Act. Please be aware that each of your lines is in a listen-only mode. At the conclusion of today's presentation, we will open the floor for questions. At that time, instructions will be given as to the procedure to follow if you would like to ask a question. I would now like to turn the conference over to Ms. Anna Wojcik. Ms. Wojcik, you may now begin.
Great. Thank you, Travis. Welcome, everyone, to the July ICU content webinar. Today we'll be discussing CAUTI Sustainability, embedding CAUTI policies, using data to monitor progress, and hardwiring CUSP principles. As a reminder for those who aren't familiar with the platform, you can download the slides to our webinar in the bottom right-hand corner under the materials box. They're also available on the project website. We also remind everyone to please complete the evaluation. We'll include a link to this as well at the end of the presentation. And we'd like everyone who's participating, even if there's more than one person in the room, to complete this evaluation. We really value the feedback that you provide for us. Now I'd like to introduce our presenters today. We have Diane Byram, who is a critical care clinical nurse specialist with 30 years of experience as a critical care nurse, educator, and education department manager. Diane is currently employed by the Society of Critical Care Medicine as a program manager for the SCCM Cohort 9 CAUTI Elimination Project and the ICU Liberation ABCDEF Bundle Implementation Collaborative. We also have Dr. William Miles. Dr. Miles joined as attending staff of the F.H. Sammy Ross Jr. Trauma Center at Carolinas Medical Center in 1995, where he is currently the Director of Surgical Critical Care and the Medical Director of Surgical Trauma Intensive Care Unit, as well as the Medical Director of the Stanley Community College Respiratory Therapy Program in Charlotte, North Carolina. Our unit presenter today is Ginger Dickens, who is a nurse manager of a 24-bed critical care and telemetry department at Maury Regional Medical Center. She has 27 years of experience as a nurse with a focus in critical care, advanced practice nursing, and management, and has departmental oversight for strategic key metrics in quality, service, personnel, and resource management. And then finally, Pat Poza, who, as you know, is our resident CUSP expert, and she's also the System Performance Improvement Leader at St. Joseph Mercy Hospital in Ann Arbor, Michigan. So we're really excited to have these great presenters today. With that, I'll turn it over to Diane Byram.
Thank you, Anna. So our learning objectives for today are to examine the key lessons that learned that sustain the gain. And so I would really like to be able to offer you some firework, here's some new information kinds of things, but we all know that if it was out there, we'd already be doing it. So we're going to examine some of the things that you've already done, but all of these things that you've already done and put into place will help you to sustain the gain. And then we're going to identify a roadmap for continued success using the Tier 1 and Tier 2 protocols from Dr. Sanjay Saint's work in the Med-Surg units. So I wanted to talk a little bit about some of the information that has come from this project. Will be housed at a website called Project Impact, which is a website that was collaboratively formed from the AHRQ and the Society of Critical Care Medicine, and it will be housed under a thing called Project Dispatch. It's focused on patient-centered outcomes research and aims to provide clinicians with information on how to adapt and adopt successful interventions in their own ICUs. So this information is available for anyone to go to and look at videos or hear webcasts. So just wanted to make sure that everyone knew that there was a more global kind of ICU place that you could go if you were looking for information in addition to CAUTI about some of the best practices and some of the successful interventions in ICU. So quality health care. I found this definition, and I really like this definition. It's very old. And it says that the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with the current professional knowledge. And I like this definition mainly because I think it sort of gives that whole vision of why we're looking at preventing CAUTIs. We never want to cause harm when someone comes into the hospital. And I think our current professional knowledge tells us that we shouldn't do that. And we need to put those practices in place that will allow us to provide the best care that we can for our patients who desire a good health outcome when they leave the hospital. Begin with the end. I'm not sure I went one too far, sorry. Change requires respect. And when you think about how you've always done things and how you were taught to do things and how after 40 years as an ICU nurse, someone's going to come along and say, well, you need to do this differently and this needs to change and this is just how we're going to do it. So I want you to think about that change requires respect. You have to respectfully think about the past. You have to realistically talk about the future or the present, and then you have to optimistically speak about the future. And so when we are trying to get people to buy in to CAUTI reduction or CAUTI elimination or any kind of new initiative that we might have in the ICU, we have to keep this in mind. Change requires that we respect where people came from and that we provide them with the tools to move forward and that we're optimistic that in the future we will be able to make a difference. So begin with the end in mind. If anybody ever read the Covey book, you know that comes from Stephen Covey, who said anytime you start something, you have to begin with what you think the end might look like. Remember that quality issues are often process-related and not people-related. People are a part of it, but usually it's a process. If you fix the process, you usually fix the problem. And so not to steal any thunder from Pat Posa, who will present at the end, but a couple of things about fixing processes are you have to standardize and they have to be simple. You have to decrease reliance on individual decision-making. If your process for putting in a Foley or how you get equipment or how you do things is very complicated, it's likely not to be followed. And there has to be such redundancy and such practice about making that process that you have decided will be standardized and simplified so that it doesn't allow for someone to make a decision outside of that process and then possibly cause harm. So, sustaining the gain. You have to recognize that change takes place over time. For some of the people in this project, you may have started at square one. You hadn't started any kind of process in your ICU about eliminating CAUTIs. And so you have to understand that when we finish this project in August, that you may not be exactly where you thought you would be, but you have to continue to believe that over time things will change. The problem is that people stop changing when they don't see results immediately. And so if you do that because you say, well, we didn't make any difference, it's not going to happen overnight. It's going to take time, and over time you will begin to see that. So other lessons learned, ensure administration is aware of your efforts and your results. And I don't mean this in a derogatory way towards nurse managers in any way, but if you're the leader in your unit of this CAUTI project, make sure that your nursing administration knows about what you're doing and the processes and the gains that you've made. And you also want to, for the physicians, to make sure that your CNO or your CMO knows about the results that you've made, that goes all the way up to the administrator, that goes all the way up to the board of the hospital. They want to hear things like this, that there's a project out there and we're working on it and we're making huge strides in giving better care to our patients. Encourage and reward participation and problem identification. So as people begin to identify that, you know, there are things that aren't working or they're really doing a lot to make the process work, then you want to encourage and reward those people. And, most people enjoy being praised in front of their peers, so anytime that you can have that opportunity to do that, it really goes a long way. And the biggest thing for sustaining gains and losing that gain is complacency. And I won't read you the definition of it. I'm sure that many of you know what complacency means. And I think sometimes we think we're there and everything's working and we don't really need to do anything else. That's when you start to see things slip. So I would caution you about being complacent with where you are. Keep CAUTI projects on the front burner. Talk about them in staff meetings. Create healthy competition within units. And if you have not had the opportunity to watch on YouTube the story called Jerry's Story about a person who came into the hospital for a simple hip replacement and what happened as a result of a CAUTI, I would ask you to show that in a staff meeting. It's 4 minutes, or to ask your staff to watch it, because I think it really gives you the behind the scenes, what really happens and can continue to happen when someone just develops a urinary tract infection, which is sometimes how we think about it. Continue to work on staff competency. If you have not done that as part of your project so far, then I would challenge you to continue to work on how are you going to ensure competency on not only how to insert a Foley, but how to making sure that people know how to care for that Foley once it's in. And while it is about taking care of the whole peritoneal area, it's really about taking care of that Foley and making sure that everyone is following the process as it's decided in your facility. Hardwire Foley education into all of your new employee education. Lots of us have turnover. We don't like it, but sometimes that's just the name of the game. And so it means new employee orientation, not just new nursing orientation. So it means physicians that come on board, new assistants, if you have nursing assistants, new nurses. So anyone new that comes into your facility, whether it's a transporter, someone in radiology, should have a piece of this Foley prevention information in their orientation in some way, because we can't sustain the gain if we have a lot of new staff members that don't know where we've been and where we're trying to go to. Short-term, attainable goals, so don't try to do everything at one time. Celebrate success. On my visits to in-person meetings as well as to site visits, I heard some very fun and creative ways, and we've heard that on our content calls, to celebrate. If you go a week without, sometimes you won't know that, but let's say you go a month without a CAUTI, celebrate that, especially if you've had one a month for the last 12 or 14 months. Celebrate what you've accomplished, but raise the bar a little each time so you don't become complacent. So each time that you accomplish something, raise the bar a little higher. Continue to engage naysayers, because you're going to continue to have them. Well, that's not the way I learned it. Well, that's not how we ought to be doing that. You've heard the gamut of all of the things that people can say. So I would challenge you to continue to engage them. And sometimes the best way to engage them is to invite them to be a part of your team, because maybe they do have really good ideas and no one ever asks them for their opinion. And treat a CAUTI with respect. I know that Pat has talked in the past about the Learning from Defects tool. If you have another tool that you use, I would challenge you that anytime you have a CAUTI, you drill down and figure out what went wrong and fix it. Because if you don't fix it, you don't know what went wrong, and then you don't fix it, you likely will continue to have that problem. And then in an effort to not take up any more time, I'm going to talk to you just a second about this Tier 1 and Tier 2 protocol. Dr. Saint published this as part of his original publication about the Med-Surg unit. And I would say to you, if you don't have all the processes in place at Tier 1, then you can't move to enhanced processes in Tier 2. And if you begin to have problems, then you probably need to go back into Tier 1 and make sure that all of those things that you thought you had fixed are truly fixed. And then to lead into the next discussion, which is going to be about data driving practice and improvement, I would say to you, when you have CAUTIs, put a face on them. Don't just make it a bar graph with a number. Put a face on them so people understand that there really is a person behind that number. And then when you get to 0, make sure that you celebrate. I will turn the call over to Dr. Miles.
Thank you, Diane. Welcome, everyone, for this afternoon. My presentation, we will be discussing how to use data for sustainability. We have a very robust group of objectives, and we have a lot to cover. And I want to say I will be happy to provide any additional information on the slides we present and answer any questions that come out of it. We will review some of the concepts in utilizing data to sustain healthcare and initiatives, learn how to use data to change culture and maintain results. And I also want to review how many hospitals that have been successful in using data to sustain a process, as well as maintaining that patient safety goal and establishing a culture of confidence. The power of measuring results. I like this, although it is a relatively older study, but it looked at information adapted from Osborne and Giebler in 1992, but it's pertinent even today. We really have to measure results to see success, and we need to reinforce behavior to achieve success and to sustain it. And through this consistent measurement, validation, reporting, and rewarding, you can really achieve and sustain those goals. Learning from data. This is important because whenever we present data and review data and validate data, we all don't define a process the same way. We don't all assume steps without spelling them out. We don't all address a problem in the same way. Without using data and validating that data, we will not get the same results. So we really need to work together as a team in reviewing, addressing the data and addressing the issues and moving the ship, so to speak, in the right direction. I like this graph. It's really a model from 10 steps to designing, building, and sustaining a results-based monitoring and evaluation system. It actually came from the World Bank, but it is actually very good and useful in healthcare processes. It really demonstrates how to use baseline data and monitoring results, evaluating them, and using the findings appropriately to sustain the mission, and going through the whole process from 1 through 10. And we're already at really 6 and 7. It's really getting to that 10 component of really monitoring and evaluating the data. And we really need to be fluid with the understanding of the data, use it real time, adapt with ease from the data to get to the end result. And this, a lot of times, is redundant. And redundancy in what we do in healthcare is very important for sustainability. The next few slides will discuss different models in which how to analyze data, different processes, if you will. Using the PDSA cycle, some of you already use this. You may not be aware of it in some institutions. It really is a process improvement approach to evaluate change, and it allows for integration of new and existing systems, and it really promotes small-scale, rapid cycle change. And by using it, you can use current data to troubleshoot, evaluate, improve, which gives you the ability to adapt quickly and better ability to sustain your successes. And really, the object of the PDSA cycle is plan, do, study, act. Plan, you may need to alter your questions and change the capturing of data to get answers. And this is even very important in processes that you've been using for a while. You need to go back, and after you look at the data, if there are different results than you expect, come up with questions and predictions, why it happened, and then, again, start a PDSA model. You do documenting the problems again and analyzing the new results. Study, you compare the data and summarize what is learned. Action, make changes in the process to improve outcomes and maintain good results. And really, the repeated use of this cycle, like I mentioned earlier about redundancy, is very important. We already have a process and plan in this CAUTI initiative, but we really need to have repeated use of this cycle to be successful in analyzing the data and moving forward. Really using the PDSA cycle for testing or adapting a change, implementing an improvement, spreading improvements to the rest of your organization, whether it's your own institution or whether you're one of many hospitals in a system. This is important to use, and maintaining this process by reassessing and making it current. And by using it, you can be active, iterative, and learning. It really allows us to be quickly, or to use it quickly, to be active over repetitive cycles, but we actually need to learn and take time to study the effects on our actions and our processes to be successful. We also, most of us have used root cause analysis to look at special safety events, and I think it's a good process to really look going forward, using it for every CAUTI that may occur. Hopefully we have ability to sustain a major reduction in CAUTI, and that's really what this is about. It's a way of looking at unexpected events, the data results and outcomes to determine all of the underlying causes of the event. Thinking outside the box, not just in your own unit, but where our patients actually travel to, where, what other ports of entry a patient may have come, what other services departments may have actually laid hands on the Foley, laid hands on the Foley bag, things like that. This data can be then validated, vetted, and changes made to achieve sustained outcomes. And really, the RCA tools answer the 5 whys. Appreciation of the information. It allows for drill downs and cause and effect diagrams with fishbone diagrams. And when we do the RCAs concerning CAUTIs or patient safety events, we really need to do them regularly, effectively, and then we need to publish the data and the results and be transparent. The successful units, these successful institutions are the ones that are transparent. I like this slide and this quote from General Powell. Success, there are no secrets to success. It is really the result of preparation, hard work, and learning from failure. Many of you, as I move to the philosophy of carrots and sticks, many of you have heard me speak about this. And I want to go into some of the research behind it and some of the publications. There have been many studies that actually discuss it. We'll go over a couple of them. Really, this highlights really the carrots and sticks issue. We think we know what carrots and sticks may be. I think it's important to know your local hospital culture and what drives your employees and staff to maintain the patient safety initiatives. Carrots could be CAUTI Carnival, could be CAUTI Cash, increased bonuses, incentives of whatever that would stimulate that change. Sticks could be negative incentives, also peer pressure, be it in nursing staff or actually physician staff is even more important with peer pressure. That's really how you can help break down barriers to physician resistance to follow initiatives. If you think about it, the CMS value-based purchasing is the ultimate stick. I borrowed the next 2 slides from Dr. Coe, who presented a few weeks ago, and I think they're very important in talking about how to use data to maintain improvement. What she talked about was using data for feedback and have it be a rapid cycle, repetitive, and very frequent. And use data to generate awareness, never to inflame. It's how you maintain engagement of physicians and nursing staff. Also, how using evidence-based guidelines that are on the collaborative websites could be very important as needed to support the plans. She also talked about presenting data on the specific results, present the business case to reduce CAUTI. Using the data initially and regularly, talking about prevalence, morbidity, mortality. And as you progress for sustainability, sometimes you have to go back and present the business case for CAUTI prevention. Sometimes successful programs with changes in healthcare, reimbursement, et cetera, resources may be limited, and sometimes we have to go back and present the business case of why CAUTI prevention is so important. Going on with the carrots and sticks, which one is more important? It's not simple as choosing one or the other, and there is some research behind it. And The Economist looked at designing rewards and the carrots versus sticks presented in 2010. Success depends on the spin you put on the incentives, and having incentives be real-time. And they may need to change depending on how the employees change or other things develop. You need to have continuing strategies that your institution may employ to maintain that success. And one thing, as I will show, is that carrots versus sticks may actually be more important than one or the other. What The Economist showed is that presented an incentive bonus could equal a good performance, and that most would consider a carrot. But they also showed in their study and how they methods utilized it is an incentive bonus minus a potential penalty actually equal to better performance, and that's considered a carrot dressed as a stick. And clearly both of these programs really relied on carrots, but in one the carrots were enticingly dangled to motivate a positive effort, while the other, the carrots were actually frozen. The incentive was frozen and used to give employees the occasional little kick when needed. And what they discovered that fear of loss was actually a better motivator than the prospect of gain. This may be one way to maintain and sustain success, when they showed that carrots may work better if they can somehow be made to look like sticks. The New England Journal of Medicine Redesigning Employee Health Incentives showed in 2011 that the data you use and the results you rely on must be real-time, transparent, and acted upon often and quickly, and that several factors might influence the outcomes. The most common implementation mechanism is less effective dollar for dollar than other approaches. One of these key factors is that most individuals place more weight on the present than the future. They're more attracted by the immediate than the delayed benefits and more deterred by immediate than delayed cost. And that's keeping it real. I think there are some barriers for using data and to maintain sustainability. We've seen many of these, and I think it's important that your institution, as you lead this initiative, to make sure it can be sustained, and to recognize the barriers. It's not using the data effectively. If you're not meeting regularly, reviewing it, not really doing the RCAs, drilling down why a CAUTI, a patient safety issue, may occur, it's a barrier. Validating and discussing it with outliers, the outlier physicians, the outlier nursing staff, whatever outlier there may be. Not using data as part of the culture of safety, not having explicit intent to continue a program and resources. We've seen that before, where a lot of times it becomes more of a process and a lip service and not the active resource utilization that is needed to sustain it. And I think one of the other things we have to be careful of in barriers, and we've seen it often enough, when you have an excellent team with excellent dynamics and they've done well, many times some of the team members get moved up in the administrative ladder and the team gets altered. And I think we have to be aware of that to help maintain success. Many of the institutions that have been successful in sustaining that success, it won't matter if a team member moves on to another career or leaves. They've been able to maintain that success by keeping all the culture the same, so no matter who moves into that team, it is sustained. I talk about creating a culture of confidence, and I've mentioned this before, and I think this is really what it's about. When we've been successful, you get confidence. How to maintain that is creating that culture of confidence where it becomes the norm. And confidence is at the very heart of all the effective performance of what we've seen. Professor Cantor actually talks about this, is that confidence comprises positive expectations for favorable outcomes. And that's great, because on the way up, success creates positive momentum, People who believe they are likely to win are also likely to put that extra effort into maintaining it. On the way down, however, as Diane Byram mentioned, is failure feeds on itself. Growth cycles produce optimism. Decline produces pessimism. How can we build and maintain that culture of confidence where success cycles are amplified and failure cycles are minimized? You have to build awareness of strengths. You have to cultivate a positive, appreciative environment. You have to ensure leaders and managers model the way. It's not just lip service. They model it themselves also. Make customer and stakeholder feedback visible. You have to make it transparent. And building those strong, cohesive teams and social networks are very important. Building a culture of confidence is largely really about amplifying the successes and strengths to ensure the voices of possibility, optimism, and self-belief drown out the voices of self-doubt. Those barriers, the physicians that may not be engaged, this is that one way to make sure the culture of confidence maintains that culture of optimism. With the right mindset approaches, using data and results real time, the leaders can actually build accountability for the turnaround. It inspires people to optimize their strengths. To turn around a failure cycle can be tough, particularly when successive failures have occurred, which can really zap the morale and energy from a team or organization. However, like Dr. Cantor initially said, we contend that that is primarily a leadership challenge. I've visited many hospitals, site visits with Diane and with Julia Rutelsky, and I can tell you, I've seen many successful hospitals, and hospitals that have gone from a significant number of CAUTIs down to a remarkable reduction. The successful hospitals that also have been able to sustain that momentum, I think there's some examples of how they've done it is very important to relay today. Using validated resources are important. The AHI and IHI collaboratives from the beginning have been very important to utilize at institutions to make sure that the resources and evidence that is current can be utilized and maintained. Those institutions have adopted a culture of safety. They've taken the culture of safety, patient safety survey. They took the results seriously. They educate and re-educate new and established hires so that no one can come in, well, at my institution, I've done it this way. Well, no, at this institution, we're about a culture of safety, and this is what needs to be done. I think that's very important, that top-down, down-to-top mentality where the CEO, down to environmental services, also over to the patient families, are all part of the team to maintain that culture. And I think that's very important to be successful. Then they were to have a process to evaluate, validate, publish, celebrate, make that data redundant in how they utilize it. You know what works at your institution, and make that data, make the results part of that culture and behavior. Successful institutions have been transparent. And some institutions, the patients and families have actually been part of a safety committee where they allow to come in and actually round with patients and addressing any patient safety events, and actually part of the root cause analysis, overlooking and coming up with improvements relating to any patient safety problems. They've also been able to find a way to celebrate the wins and publicly evaluate the losses, and to show that they make a difference and they mean what they say in sustaining their good results. Quality improvement is a process, not an event. And I think that is very important. This process needs to be continued, redundant, et cetera, to be sustained. And I hope we've been able to show that using processes to collect, evaluate, adapt, and publicize data is important. Use the data real time, make it transparent, use specific data mining tools that work. Some institutions may need more than others. Utilize the process of carrots and sticks. I think it's important to participate in the American Hospital Association collaboratives, utilize the HR2 resources to maximize the effects of those processes at your institution to sustain that success. and to use your data to be accountable, transparent, and sustain your culture of confidence. Thank you, and I'm going to turn it over to Ginger Dickens.
Good afternoon, everybody. I really appreciate the opportunity to share our story from Murray Regional. Today, we're going to cover our learning objectives for effective team and how important the right culture is. And we're going to share a few tools that have been beneficial to us in our CAUTI prevention project. So to tell you a little bit about Murray Regional, we are the largest hospital between Nashville, Tennessee and Huntsville, Alabama. And we are the flagship hospital for a health system, and we serve about 250,000 patients in the southern Middle Tennessee region. We offer a variety of services from cancer and cardiac all the way through orthopedic and women's services. In 2014, we were the recipient of the Tennessee Center for Performance Excellence, and just this year we were designated as a Plane Tree Patient-Centered Hospital, and we're proud of this very much. We're the first in Tennessee to have this, and only one of 28 in the United States. And I share these things with you about Murray Regional not only because I'm proud of them, but I think it speaks to the same points that the previous presenters have shared, is what our culture is like at our organization and the impact that it has made on our success in this project. So we are also certified by the Joint Commission for several disease-specific care programs, and we have used the same process for improvement when we took on these projects, and sepsis is near and dear to my heart, and we just achieved that, so I wanted to share that with you. To tell you a little bit about critical care, we have 24 beds of critical care on 2 different floors of the hospital. And some years ago, from the team aspect, we were very divided. And I know that competition can be healthy, but for us, it was important to pull together and become one department and one group. It helped us focus our efforts. We have 24/7 intensivist coverage, and they are with us and required on all admissions. We are not a closed unit, but every patient that comes to us is evaluated by our intensivist. And we encourage our staff to maintain their education and certification. For this project, our team design included a physician champion, which was our critical care medical director, and the infection prevention, most certainly the frontline staff. Clinical education, wound care, supply chain was involved, and our senior leaders and administration. I'm going to start a little bit earlier than the recent project that we've all been working on, but I wanted to tell you about it because CAUTI's been an initiative that we've had for a period of time, and we were in a prior cohort once before, and I think that helped us gain a little foothold getting started. And some of this may be redundant to you, or you may already know about it, but hopefully you can take some nugget away if you've not thought of these things. In 2012, we formed a unit-based team of frontline staff and began to drill down into what else could we do to help prevent our patients from having a catheter infection. And we figured out that our external catheter options were not ideal and that we needed to take that back to our product committee and standardize what we were using. We also updated our physician order sets for post-op day number 1 post-surgery and get those catheters out, and had stickers in place. And we've transitioned more to electronic charting since then, but there is still a paper trail, sometimes more paper than before. And the Foley stickers were a bright color and a helpful reminder. We also standardized our securement device, and we even realized that we had different products in the building, and the Foley bag itself, when you went to empty it, had different types of closure devices. And the staff were concerned that that would contaminate the Foley bag itself and possibly allow bacteria to translocate. So we had to standardize that. We also decided to start covering the sample port on our Foleys, much like you do the IV port on a IV tubing. And our nurse-driven protocol for catheter removal was implemented in the summer of 2012. So in 2013, we took all of our critical care nurses back through a documentation review. And I'm going to show you some screenshots of the documentation that we use. And our electronic medical record provider is Meditech. Some of that may look familiar to you if you use Meditech. But in the spirit of preventing hospital-acquired infections, we went a step further and also took down all the curtains out of our patient rooms. And our windows are glass across the front of our patient rooms, so the bottom half was tinted and the top half had mini blinds. We installed those. They've been much easier to keep clean, and environmental services loves it, the staff love it, and there's not been any issues with privacy. We also added sinks in our hallways, and our practice, is not gel in and gel out. It is gel in and wash out. And every time you're coming out of a patient room, you better head to the sink and wash your hands. So it is really ingrained in us to prevent any kind of hospital-acquired infection through the hand hygiene. We also decided that we would consider, if a Foley catheter was present on admission, that we might take that out and reinsert it so that we knew that it had gone through the proper technique, and that was only if it was not contraindicated. Then in 2014, we made a big push. We had done some education right at the end of, in December of 13, and decided that we were going to follow the Universal Decolonization Protocol, and our patients were given a CHG bath within 4 hours of admission to critical care. We also had a large campaign for physician education on antibiotic usage and urine culture stewardship. They updated their physician order sets, and we were able to eliminate automatic urinalysis. And even with the lab department, if you have not drilled down with them and had specific conversations about what happens behind the scenes, because when a urinalysis is sent to the lab, we were not aware until we had some CAUTIs and we had conversations with them that if a certain number of white cells show up, they were going ahead and doing a culture, whether it had been ordered or not. It was just part of their process. So you have to dig deep sometimes and have some very detailed conversations with other disciplines. We implemented a competency, a house-wide competency, and this wasn't just critical care, but this was everywhere for all of our licensed staff. And they did the Science of Safety video. They went back to basics on education for insertion technique and a maintenance bundle. And that was key. Even our assistant staff, the nurse techs and patient care assistants, learned the maintenance bundle care. We developed a CAUTI status board, and the status board is an electronic tool that is used, and it's very beneficial for our charge nurse staff who need to look at a broad group of patients at one time and figure out who's got a catheter, what date was it inserted, is it still needed, when does it need to come out. It's just a great snapshot tool. We developed pocket cards and updated our policies and gave all those tools that the staff needed to help them be successful. And last summer, we decided as an organization, a department, and then individually as a personal goal for every staff member in critical care that it would become part of our personal goal that reflects on our performance appraisal if our patients have a CAUTI. And CAUTI reduction has been on the forefront ever since. It made it a very important goal that people took to heart. So this is a screenshot of our urinary catheter insertion assessment, and you can see that it tells you and makes you mark whether the catheter is needed and what it's needed for. And then on the Genesee urinary shift assessment, the same thing is there, and this is required every shift, and it's a hard stop at the bottom. You have to say whether the catheter is needed or not and then why. This is a screenshot of our CAUTI status board, and this, depending on how many patients you add on this, you could add as many patients as are on your unit or your floor or however many you need it to select. But the lead charge nurse in the critical care used this in conjunction with a paper audit, and I'm going to show you that a little bit later on, but it really allows them a quick look at the patients and who's got a catheter. This is the HCPAC guidelines, and it's what we used for our physicians to help educate them on the recommendations for a catheter and when patients need them and when they don't, and why they need medical assessment by the provider. And it has to be documented. So once we did these things, we did some follow-up audits, and we figured out that we had a few things we needed to improve on. We had to change our supply stock in the emergency department so that the patients coming to critical care would already have a catheter in place with a urimeter. Sometimes we would get some with the urimeter already on it, and then other times we wouldn't, and we would have to change that out. We also figured out we didn't have anywhere to hang a Foley catheter when we took patients for a CT, and that was something that came up just by talking to the frontline staff. We also realized that catheter care for that maintenance bundle wasn't really being charted the way that it should have been, and we had to go back and do some education for the nurse techs. So another thing that we added as a follow-up measure was having that lead charge complete the audit tool. We revisited our interdisciplinary daily rounding tool also. That tool is very generic in a sense that it covers some broad topics because we use it for 7 days at a time. And any line or any tube that's in a patient, we want it to come out as soon as it can if it's not needed. So it's generic on there, but we realized that we needed to get back to a conversation with the physicians and our frontline staff about don't overlook the Foley catheter, don't assume just because they're in critical care that they need one. And then our patient safety committee, which is interdisciplinary, and it has our chief medical officer, infection prevention, our directors of nursing, our assistant chief nurse, all the way to frontline staff and environmental services and food and nutrition. Everybody's on this committee, and we do quarterly rounds out on the floors and all the units, inpatient and outpatient, but we weren't asking anything about catheters. And so we made the decision to add that, and talking to the frontline staff really helped open our eyes about catheters and how comfortable did people feel using the nurse-driven protocol to take them out. And what we came to find out is that not everybody was that comfortable. So we had to go back and do some more education, and it was just a reminder to us that simply because you put something in place doesn't mean that everybody got it, that everybody's okay with it. And so we revisited our audit tools, and we solidified that thought that we had kind of earlier on in 13 about changing out catheters that come to critical care, and we really made that part of the process that we change them if they have a broken seal. This is the lead charge nurse audit tool, and they have to fill this out. And, of course, it covers other things, but Foley catheter, if that's still needed, they have to put a reason code, and we have a key for them to go by, and it's based off the guidelines. And they send that to infection prevention and to the nurse manager. Then this is a screenshot of our interdisciplinary rounding tool, and we have team rounds every day with our intensivists and the frontline staff. Now, our data, you can see we struggled for some time, and then in January of 14, that's about the time that we implemented the CHG baths, and our physician order sets were updated, and we had education for them. We did well for several months, and we were very proud of that and glad that we had the successes that we did. We did have a blip in November, and you have to stop and kind of like the previous presenters, you have to celebrate those successes and mark the milestones. So prior to November, we had unit celebrations and talked about it in our staff meetings. It is on every staff meeting agenda. It's on every charge nurse meeting agenda. And we celebrated and recognized the team and had management team recognize the staff for the work that they had done. And that means a lot to hear your senior leaders come behind you and pat you on the back and be proud of what you've done. But we did have that blip in November, so what happens when you have a CAUTI? you have to drill down into it, and we use an analysis tool, and there is team notification. The minute that it's decided that, yes, this is going to be a CAUTI, it meets the criteria, everybody knows because it matters to everybody. And we have to report out at the Infection Prevention Council. This is our analysis tool that we have, and it asks some very specific questions and helps us drill down into the reasons of why that the CAUTI could have occurred. We report our data at the Critical Care Committee, which meets every month, the Patient Safety Council every month. The Quality Council is quarterly, but all of these meetings have chief medical officer, our medical directors, our frontline staff, our nursing leaders, and I have to say having that senior leadership support and administrative support, and they partner with our Tennessee Hospital Association leaders, and from the bedside to the boardroom, it matters, and they have been instrumental. And I guess I say all of this to tell you that it really is who we are. It's part of what we do every day with every project that we take on. This is just a screenshot of our visual management board. It's right in the unit when you walk in. Families, patients see this, staff see this. We share with everybody whether we're doing well or whether we're not, and we're totally open with it. And another measure that we have in place for transparency is on our intranet inside the hospital, you can click on and see the last time that anybody had an infection of any type. And this is a screenshot of the critical care unit, but you can compare yourselves to the other units. They're right there beside you. This is a quick screenshot of our shift huddle. This is how we start each shift. We have a rundown of our patients, and we talk about CAUTI at the beginning and where are we, who's got a catheter, what's our target, and what are we doing. It's on the forefront of everybody's mind. And our CUSP initiative takeaways really focus on the team and engage in those frontline staff because they're going to tell you what works and what doesn't. And then having senior leadership support behind you, because if you need a new product brought into the organization or if you need to make a change that impacts more than your department, you have to have someone backing you up. And you have to have safety. It's a system design. And if your system doesn't work, you're not setting your team up for success. And then to review your processes, educate it and execute it. And go back and look at what went well and what didn't and learn from that, and then communicate it out to your team. And understand, for us, we know that we have to carry it forward, and this wasn't just a project. It really is who we are. We share this with everybody that comes on board as part of our critical care and hospital orientations. And the common goal that we've had has enhanced our physician and nursing relationships. They are true partners in fighting against hospital-acquired infections. And to quote one of our senior leaders, they said, gosh, we just wish we had done this sooner. So I'm going to turn it over to Pat now. Thank you.
Well, thank you so much, Ginger. Phenomenal work that your organization has done. Congratulations. And so I'm just going to spend the next couple minutes, and each of the presenters, Diane, Dr. Miles, and Ginger, have talked a lot about CUSP as part of what needs to be sustained and talked about a lot about culture. So I'm just going to briefly highlight the 5 steps of CUSP and then define some strategies to sustaining CUSP. So sustaining CUSP will take work, and your team should expect to face challenges, just like sustaining anything. The struggles often come because the team's lost sight of the steps of CUSP. So just a reminder that you need to set in place, understand that educating the staff on the science of safety is important, that you need to be able to identify your defects, not only CAUTI, but other safety defects. Your senior executive partnership is important, and learning from our mistakes and using the tool learning from defects to do that, and continuing to work on improving teamwork and communication. So CUSP helps us identify problems. It helps us understand what the staff is thinking that's impeding patient care versus what maybe the managers or directors are thinking are prioritizing priority areas. CUSP improvement tools are designed for the bedside caregivers, easy for the staff to use, And it puts the ownership for quality and patient safety down to the unit level and the frontline staff level. CUSP can be complementary to Lean Six Sigma and other quality improvement and process improvement tools. They're focusing on streamlining the process, which we know is important in designing safe systems, so they can work complementary with CUSP. So you want to be able to integrate and coordinate with all the other efforts going on, and so you can see Lean, Six Sigma, Bouldridge. Dr. Miles talked about the IHI's model for improvement. Back down here in the right corner is team steps, and then adjust culture. All of these can work well with CUSP. So it's important that one of the underpinnings of safety is to understand the science behind safety and the basic principles to design safe systems. And as Diane talked about earlier, standardization is important. Standardization and then carrying on that standardization and educating the oncoming staff in all disciplines what our standard processes are. Making sure that you create independent checks for those key processes. We heard, though, those independent checks, discussing it on rounds, the audit tools. Those are independent checks to ensure that things are happening correctly. And then, most importantly, learning from mistakes. You heard all three speakers today talk about the importance of any time you get a CAUTI to understand why it happened, and to use. You can use the Learn from a Defect tool, root cause analysis, many tools to again learn why it happened, and then you can better understand get down to the root causes, and then set up tweaks or changes in your systems or your processes to prevent that from happening again. So one of the things to ensure that you're applying and are integrating these principles of safe design into your unit processes for CAUTI and beyond is to assess whether or not your unit is continuing to do this by have your CUSP team name the three principles of safe design and have them write down, or you can discuss as a group an example of how you or your team has applied each of these principles. And then, again, it's a reminder that we need to apply these principles if we're going to increase the safety in the unit. Very important to continue to identify defects. Remember that identification of defects goes beyond just looking at CAUTI as a defect, and again it is, but you want to look at staff feedback, quality and safety measures, other gaps in application of the evidence. And remember that important tool, staff safety assessment, where you ask the frontline staff how they think the next patient would be harmed and what would they do to mitigate that harm. Remember, CUSP is all about tapping into the wisdom of that frontline staff because they understand it. So you might want to have that staff safety survey administered every 6 months or a year, and then you might want to keep track of the safety issues that you identified and what the status of resolution is. And so here you can see on the right hand of the screen an example tool where you're just continuing to inventory what you've identified and what you've done about it. Again, learning from defects is important, and it's answering those questions. What happened? Why did it happen? What can you do to reduce the risk that it would happen again? And how will you know that that risk has been reduced? And where will you share the learnings? You can see what's displayed on the right-hand side of the screen is the Learn from a Defect step in a badge card. And so at our organization, to help with sustainability and utilization of this tool, every employee, as they enter into our system, we review Learn from a Defects, and they get a badge card so that it's readily accessible for them. You want to measure how well you're sustaining your CUSP work. Your team can evaluate if you're achieving your CUSP mission, how are you doing on your culture of safety, and do you have a strong partnership with your senior executive? How well are you learning from your defects, and what are you doing to improve teamwork and communication? And so here's, on this slide, you can just see, you can do a review of the different components of CUSP and see how you're doing. So here's an example of a CUSP scorecard asking a variety of questions, and you could also define your own team members' measures of success. So, for example, number of CUSP meetings that were canceled in the last 6 months. Well, of course, you wouldn't want any canceled, but if you have a large number canceled, then are you really sustaining and going to sustain the work that's been going on? Percentage of the staff that have received science and safety training, the number of patient safety improvement plans that are currently in effect. When was the last time you did a learn from a defect, or how many you learned from a defect in the last 6 months? And again, the goal is to learn from a defect very often, at least once a month. I know we have many times where we have multiple learn from a defects even in a week's time. Remember, safety culture, continue to assess it annually, celebrate your successes, and ensure that based on the results, you create action plans to resolve what you found. I know we're over time, so I only have one more slide. Teamwork and communication tools. Here's a list of them. Continue to, I know we're all real busy, but pick one of these tools and implement a different tool every 6 months to a year. Other strategies, make sure that you've integrated the science and safety training into your orientation for all new employees. Encourage new staff to take an active role. Make sure CUSP initiatives are visible through bulletin boards, and you saw Ginger shared that. And make sure that you're expanding these CUSP team concepts to other units. I want to thank you for your time, and I know we're at or past the hour. If anybody has any questions, please feel free.
Thank you very much, Pat. I think because we're after the hour, if anyone has questions, please feel free to post them in the chat box. I know we already have a few questions there, and we'll be sure to share these questions with our presenters and put out a question and answer document on the website. So if you have any final questions, please be sure to post them in that chat box. I've also pushed out the evaluation, so we really do ask you to fill out that evaluation. And with that, I think we'll thank all of our presenters. I think we had a really terrific presentation today. And thank you, everyone. We'll see you again next month.